So Jay, that takes us to just thinking about prognosis and how we sort of risk stratify patients. There are a variety of instruments that have been developed. They're often used in clinical trials. Are using them in clinical practice? What about other things such as PET scanning? How do you incorporate this into your assessment of patients' risk?
Right. This is one of the challenges we face with follicular lymphoma, is trying to accurately predict who's going to do poorly and who's going to do well, and then using that information to make treatment decisions. And I think I'll start what I'm saying is really just emphasizing that we don't yet know how to use those tools to decide who gets a more intensive therapy or not. There are a variety of prognostic scoring systems, from the FLIPI, as you mentioned, which is kind of cumbersome. You got to count out nodal areas, to the FLIPI-2, which really focuses on beta-2 microglobulin and bulk of disease. There's also an M7 FLIPI, which puts a genetic signature plus the FLIPI score, which is a little better at predicting which patients are going to fall into that very high risk category. But that's not something that we can easily routinely do. It is a challenge, though. We don't yet know how to use those tools to decide which patient gets which therapy, or even which patient to initiate therapy on if they're asymptomatic.
What about PET scanning? I mean, do you think that helps? Do you get PET scans on everybody? What do you do with the information? Are you using it pre and post, or?
Right. No, that's another excellent question. PET scanning, there's controversial data. I think I typically do get a PET scan if I'm going to start therapy. We also use it when we're trying to sort out whether a patient might have transformation before we start, and we often use it to guide biopsies. But in terms of the data as to whether a PET scan will predict outcome, they're differing results. There are two abstracts from this meeting, one looking at metabolic tumor volume, which suggested that it was not predictive of outcome, and then a second one looking at SUV, which suggested it was. So, I think that the data are still a bit controversial as to using PET scan to predict outcome, but I think it is useful as a baseline study.
Nathan, are you getting PET scans on everyone pre-treatment, or majority of people?
I totally agree with Jay's comments that I think it's extremely valuable, especially at diagnosis. I found that it often will guide biopsies, and if you go after the hottest node, sometimes you'll pick up an occult transformation. So it's very, very sensitive. As 97% of patients have follicular will have a hot PET, and it's extremely useful. And also, I find that there are occasionally sites of extranodal disease which will not get picked up on CT and are seen on PET. So yes, I do use it pretty much all the time baseline.
So we talked about PET scanning on the front end, trying to figure out where to take patients and things like that. But how about afterwards? Are you getting PET scans routinely after someone completes therapy? At what interval? And any problems with that?
So in my practice, I really like PETs for follicular lymphoma, again, because they're positive if patients have disease. They can have false positives, but generally, I think with a good clinical exam and history, you can rule out what is positive. I mean, if patients come in with a cold or a flu and they have hot nodes in the hilum, it's probably not relapsed lymphoma. And so I find that, at least in our hands, with a good nuclear medicine physician and a good understanding of what's happening with the patient, we don't have a whole lot of false positives. I think in current practice, it's very rare to get a PET without a CT at the same time. Most centers are now on PET CTs. And so when I think about, again, radiation exposure to the patient, it's the same whether you get a CT or a CT PET. And the cost, at least in our center, is fairly similar. Now, most, I think, payers will not agree to PET imaging as surveillance or in a certain time span. But in my opinion, if you're going to get a CT, I don't have any downside of including a PET because it just adds additional information that I can use or not use depending on the clinical picture.